I'm Peter Schmid. I'm a medical oncologist and work at Barts Hospital in London. It's my pleasure speaking to you today about really the exciting advances we have seen in recent months and years with antibody-drug conjugates, and in this case with antibody-drug conjugates or ADCs that don't target TROP2 in metastatic breast cancer. I want to build this around a couple of cases. The first case is a patient from our hospital, 56-year-old woman, BRCA, Walden and PALB2 wild type. She initially presented back in 2015 with left-sided breast cancer, locally advanced, ER-positive, HER2-1+, received neoadjuvant chemotherapy, then surgery, still had residual disease in breast and lymph nodes. At that time, received adjuvant endocrine therapy with letrozole. Unfortunately, this lady experienced metastatic disease recurrence in liver, bone, and lymph nodes, which was rebiopsied and still found to be ER-positive, but HER2 was 0 at this time. This was about 3 years after she started on adjuvant endocrine therapy. She received first-line metastatic endocrine therapy with fulvestrant ribociclib, had then progressive disease within 10 months, again in liver and bones. We did some genomic testing. We found that she was wild type for ESR1 and for PIK3CA. We tried second-line endocrine therapy with exemestane and everolimus, but again, patients progressed within 3 months on this treatment in liver and bone. And the question really at that time is, what would you do in such a situation? Would you give further endocrine therapy? Would we switch to capecitabine therapy? Would we switch to paclitaxel? Would we switch to an antibody-drug conjugate? At this time, we switched to paclitaxel. I mean, if you look at the date that was in 2020, some of the data I'm going to share with you in a minute on ADCs were not available yet. But if you go back to the treatment strategies we had at that time, first line endocrine therapy, clearly a combination of endocrine therapy with CDK4/6 inhibitors, and then a series of endocrine therapies as long as the tumor was hormone sensitive. Once the tumor is hormone refractory, the standard of care at that time was serial chemotherapy, with unfortunately decreasing the efficacy as we go from first to second, third line treatment. Now, one of the big changes in this setting is obviously the antibody-drug conjugates. This patient here in your example, unfortunately experienced disease progression within 6 months of starting on paclitaxel. She had 3 small brain metastases, but also a progressive disease in liver and peritoneum. We first treated the brain metastasis with gamma knife treatment. And again, the question to all of you, what would you do? Would you rebiopsy the disease? Would you give capecitabine now as she had paclitaxel before? Or is this now an indication for an antibody-drug conjugate, for example, trastuzumab deruxtecan or sacituzumab? You're well aware of the strategies of antibody-drug conjugates, how they have changed, and the biology in this situation is very very unique. We know every ADC has 3 components. There's a component binding the antigen. There is a linker, and then there's the so-called payload, the chemotherapy drug that's glued to the antibody. And what we have seen over years, the initial concept or understanding of ADCs was that the ADC would bind to the tumor cell, would get internalized, the antibody would be broken down, and the chemotherapy released into the inside of the cell, where it can ultimately kill the cancer cell. But we've learned with the recent generation, with the next generation of antibody-drug conjugates, which we are now using in routine clinical care, that there are additional really important effects, and these effects drive the increased activity we are seeing now. One is that the chemotherapy drug can get out of the cell again. The other effect is that the chemotherapy drug can be released upon binding to the cell surface protein. Both of this leads in a mechanism which we call bystander effect. And if you look here in the little cartoon, the pink and the blue cells, pink cells being target positive, blue cells being target negative. If you don't have a bystander effect, you only take out the target positive cells. Whereas if you do have a bystander effect, you can also have what we call collateral damage, but in this instance, take out target cells that are not negative, not positive.
Could I just ask, I don't think I've heard anybody talk about extracellular release. I've always heard of the other idea that it gets inside the cell and then effluxes out, but you're saying that it actually could release before it gets into the cell?
In some instances, that is possible with some of the new ADC technology. Again, upon binding and using the local proteases to release the payload in a targeted way. But that, of course, increases the opportunities in terms of targets we can select, because not every target will allow internalization of the antibody. And I think that's an interesting part of the novel technology.
Yeah, that's interesting. The other thing I wanted to ask you, and I brought this up to Sarah yesterday, which is, when you hear investigators discuss things, a lot of times you hear, okay, CDK, and then, post CDK, SERDs, the PIK3, et cetera, et cetera. But yet, when we talk to oncologists in practice, a lot of them are questioning whether to even do second-line post-CDK therapy. So my question to you, particularly if you have a patient maybe who has symptoms, do you really get very much out of post-CDK endocrine therapy? I know we talk about it all the time, but does it really have a meaningful impact at this point?
It's a good question. And I think there's no straight answer. It comes down to the individual patient. So if you have a patient who has a very long time on first-line therapy, then there's a very good chance that this patient benefits from second-line endocrine therapy as well. On the other hand, if, as in this case, the patient progresses within a year on first-line endocrine therapy in combination with CDK4/6 inhibitors, the chances that this lady responds to a second-line endocrine therapy are very low, especially as we couldn't identify a driving mutation. So I think it comes down to the individual case. If you have a patient with 2.5 years on first-line AI plus CDK4/6 inhibitor who then develops an ESR1 mutation, it is very clear that this is still an excellent candidate for further endocrine therapy, ideally with a drug that targets this ESR1 mutation in the form of an oral SERD.
I guess the thing that I wonder about is, and it's kind of hard to understand based on just looking at data, is like, do you actually see meaningful responses post-CDK? I mean, I know people can go a long time before they progress, but some of that could just be in the natural history of the disease. So, like, do you actually see people have tumor shrinkage with, SERDs, for example, the way you do with chemotherapy?
Yes, it's an excellent question. We do see tumor shrinkage, but also these days, as we monitor patients very carefully, a lot of disease progression we observe is pre-symptomatic. And therefore, patients are oligo or asymptomatic at this stage. If you then can just stabilize the disease for 6, 8, 10 months, for me, that is a real benefit, because we keep patients another 6, 8, 10 months of chemotherapy, which obviously has associated toxicity. And it's not always the big leap we have to make. It's a sequence of different treatments that can control the disease for 6 or 12 months that will ultimately get the patient, as long as we hopefully can get the patient with the disease well controlled.
Actually, I think the thing that you said makes the most sense to me. I think this would be the most helpful for oncologists, which is the amount of time they're on the CDK. And that's an easy thing to look at. And it sounds like maybe, like you're saying, if they're really only on the CDK for a year or less, I don't know whether they get much out of second-line endocrine therapy. You tell me.
So the data are very interesting. If you look, for example, at patients with ESR1 mutations who then get single-agent LSS in the Emerald study, and other studies now show very similar results. Patients who had less than 1 year of treatment on the CDK4/6 combination before and had literally a very, very limited benefit of 2, 3, 4 months. Whereas patients who have more than a year had 8 months on average duration of response if they were treated with single-agent endocrine therapy. So I think the principle that endocrine-sensitive patients should get endocrine treatment and endocrine-refractory patients should be moved on to chemotherapy or targeted chemotherapy, which we'll discuss in a second, that hasn't changed. But what will change is our understanding what is hormone refractory and what is hormone sensitive. And I think in the future, there will be patients where even after 1 line of endocrine therapy, we will proceed with targeted chemotherapy, whereas other patients will still have 2, 3, possibly 4 lines of endocrine treatment.
Yeah, I think that's something we need to emphasize more. Let me ask you another related question. Overall, how often, when you see, globally, if you were to take, 1,000 people who progress on CDK, like roughly what percentage of them would be like endocrine resistant? They only on CDK for less than a year. Is that like very uncommon? 90% of people are on more than a year, or do you see a significant fraction who progress in less than a year?
It's an interesting question. I think it comes down to what patients you treat when they start on CDK4/6 inhibitors. Again, if you go back to what I would call AI sensitive or AI resistant, so patients who relapse whilst on adjuvant endocrine therapy or within a year on adjuvant endocrine therapy or afterwards. And we see, obviously, as we give endocrine therapy for a longer period of time, we see increasingly patients relapsing on endocrine treatment, and therefore they may already be AI resistant and therefore have slightly less long response, or slightly shorter response, I should say, to first-line combination with CDK4/6 inhibitors. That I think will be enhanced with the introduction of the adjuvant CDK4/6 inhibitors, where obviously we hope to cure an extra third of patients, but those patients who have disease recurrence are again likely to have slightly more aggressive disease recurrence. And then the very early data we're seeing coming through, that some of these early relapses post-CDK4/6 even have changed to triple negative biology.
Yeah, that's another really important factor. And I'm not sure, I have to go back and look whether or not the guidelines, NCCN, et cetera, have that as an algorithm, whether or not because I don't know that people are really on top of this, but well, maybe we can talk about it at the webinar. It's a very practical point, I think.
I think it's really important, and it's one of those things that are very difficult to capture in guidelines, because guidelines are trying to simplify matters, but ultimately it needs clinical experience and parameters to make the right decisions.
Yeah, no, I just assumed everybody was just automatically going to second-line endocrine therapy, and then I started hearing oncologists saying, whatever, they didn't like alpelisib, et cetera, they just want to skip it.
Yeah, so for example, the patient I'm sharing with you today is a classic example of where you can question the second-line endocrine therapy optimally indicated. And as a result, this patient progressed on second-line endocrine therapy basically at the first scan after 2.5 months.
Right. That's a great point. Okay, please continue.
Yeah, if you look at the development of antibody-drug conjugates, again, that's interesting. We are currently in the third generation of ADCs. The first generation didn't really play a role in breast cancer. They were quite heterogeneous drugs, low efficacy, narrow therapeutic index with quite a few off-target effects. The second generation, the drug we have been using in breast cancer is TDM1, but there are obviously other drugs in other disease types. Humanized antibodies, the change was its improved targeting. They're more potent payloads compared to the first generation, lower immunogenicity, but still quite heterogeneous in its efficacy, and had a relatively fast clearance, relatively quick development of drug resistance. The drugs we are working with now, third generation, trastuzumab deruxtecan to mention, or sacituzumab as a top-2 target ADC, these are ultimately better monoclonal antibodies. They have higher efficacy, and even with lower antigen expression, which is one of the areas we'll talk about in a second. We also have more potent payloads, and as a result, also have less off-target toxicity. The development is carrying on, and the next generation, we can only speculate what's happening, but we will be working with fragments of antibodies, bispecifics, pro bodies that have antigen masking, site-specific conjugation. But I think the main effort, the main focus will have to be on getting different payloads in. At the moment, the chemotherapy drugs we bind to the antibody-drug conjugates are relatively limited. We're essentially using 2 classes of drugs, and the drugs license at the moment is 1 class of drugs. And so we desperately need to get more effective chemotherapies glued to those ADCs to optimally use the potential of these drugs. Now, one of the points we discussed before is target expression and ADC activity. And with the second generation, it was really important that we had homogeneous and high target expression. Otherwise, those drugs didn't work. If you look at TDM1, it only worked in HER2 high disease, or HER2 positive disease, as we used to call it, but didn't really work in HER2 low disease. Now, the third generation, and trastuzumab deruxtecan is one of the examples, they have this increased bystander effect. And as a result, they work not just in high, but also in tumors with low expression of the target, as you can see here in those pink cells that are mixed with the blue target positive cells. And we've just recently learned, and we'll talk about it in a minute, that even in ultra low target expression, this is less than 10% of the cells, have a little bit of staining. So we're talking up to 1-2% of cells only that may have the target there. We can still see activity. One of the areas I'm really keen to learn a little bit more about is, I don't think it's just the percentage of cells that are target positive, but it will also be the distribution in the tissue. If you have sort of almost a homogeneous dispersion of positive and negative cells, the drugs may work much better than if you have a cluster of positive cells far away from a cluster of negative cells, because ultimately the bystander effect is still in the immediate surrounding of those positive cells. We have learned in clinical practice to define a new subtype with HER2 low. You are all aware that when we initially developed HER2 targeting agents, we saw that the benefit was limited to patients with high HER2 expression, defined as IHC3+ or 2+, at least with the gene amplified, whereas patients who had HER2 2+, 1+, or HER2 0 without amplification were called HER2 negative, even if there was some expression of HER2. We have since learned that in those patients with low expression, we can actually see activity with novel antibody-drug conjugates, and that HER2 low is about 2/3 of patients with ER-positive disease, about 1/3 of patients with triple-negative disease. But even in patients with 0 expression, with absent expression, at least in that biopsy, we can still see an effect of HER2 target with novel ADCs. What is also interesting is that the expression of low HER2 can change relatively quickly. It's probably down to heterogeneous expression in the tumor, but also to dynamic changes in up and down regulation, depending on how the cancer is being treated. And so as a result, we have a new therapeutic, but not biological subtype, that is HER2, that because it doesn't use HER2 as an oncogenic driver. And these HER2 low tumors benefit from new antibody-drug conjugates due to the payload release before it's internalized or through the membrane permeability. Important and really key message to take away: HER2 low status can be variable over time. So if you have one time a positive result, that is probably enough to select a patient. Now, going back to our patient who was here obviously in a second-line situation, the data we applied when we chose her therapy were data from the trastuzumab deruxtecan DESTINY-Breast04 trial. But this is a trial in metastatic breast cancer with low expression of HER2, low being defined as IHC1+ or IHC2+ without amplification. These patients had 1 or 2 prior lines of chemotherapy for metastatic breast cancer. The vast majority were ER positive, and 60 patients out of the 500 patients were triple negative. Primary endpoint progression-free survival. As always, it's important to look at the study population. You see this in the small yellow box. 494 patients ER positive, small group triple negative. About 58% were HER2 1+, 42 HER2 2+. Small percentage of patients, 5%, had brain metastasis. The majority of patients were third line, 61%, 29% were second line, and about 70% of patients had prior CDK4/6 inhibitor therapy. If you look at the results of the primary endpoint, progression-free survival, significant and meaningful improvement, doubling essentially of the median PFS with a hazard ratio of 0.37. And again, another really important clinical observation is the objective response rates are substantially higher, 52% in ER-positive disease compared to 16% with treatment of physician's choice, so standard chemotherapy in this setting. Similarly, in triple-negative breast cancer, HER2 low, 50% response rate, 60% response rate with treatment of physician's choice. And I think that's really important when we discuss quality of life, when we discuss symptomatic improvement, because as you said earlier, only if you make the cancer shrink, patients' symptoms ultimately get better. These trials also lead to improved overall survival. As you can see here, about a 6-month survival benefit, hazard ratio of 0.69. And the survival benefit is consistent across all subgroups. whether irrespective of pre-treatment with CDK4/6 inhibitor or how high or low the low HER2 expression might be. Another important question was obviously, is this benefit carried over in the next line? Or do you pay for that higher efficacy in that line in the next line? And actually, the progression-free survival 2, which includes the immediate subsequent therapy as well, shows the same benefit hazard ratio maintained with 0.51 in ER-positive patients as well as in all patients, despite the fact that about between 5 and 10% of patients received subsequent ADC treatment. One of the questions relevant for the patient shared today: do these drugs work in brain metastasis? And we have a lot of evidence for patients with trastuzumab deruxtecan treated for HER2 high, HER2 positive disease. And as you can see, the pooled analysis presented a year ago showed high response rates in patients with treated or untreated metastasis when they were treated with trastuzumab deruxtecan, and there was substantially better compared to the control arms. And you can see a longer progression-free survival in treated and stable metastasis, as well as even more so in untreated brain metastasis. In patients with HER2 low disease, we have slightly less information at the moment. Again, there was a small analysis of patients treated with HER2 low disease, and you can see the same principle here, that the response rates seem to be higher with trastuzumab deruxtecan in the brain compared to treatment of physician's choice, with a substantial progression-free survival of 9.7 months. And therefore, there is suggestion, despite these molecules being quite large, that they pass the blood-brain barrier. There are effective treatments in patients with brain metastasis, whether they are treated or whether they are untreated. Now, our patient had treated brain metastasis, and after the treatment of the brain metastasis, we decided to give her trastuzumab deruxtecan. And she had a good early partial response. But then after about 5 months, we saw on one of the CT scans, we showed mild bilateral ground glass changes. Patient didn't have any symptoms. And again, the question to you, what does it mean? We classified this as something called ILD, interstitial lung disease, grade 1, because the patient was asymptomatic. And what would you do in a patient with grade 1 ILD? Would you continue the therapy? Would you hold the treatment? Would you give oral steroids, IV steroids, no steroids at all, dose reduction, or discontinue the treatment? The current guidelines are fairly clear. We should hold the treatment until this resolves. We can consider oral steroids, and we can also, depending on how long the patient responds to, how long it takes for the side effects to resolve, we can also consider a dose reduction. Looking at the safety profile, again here in a little bit more detail, you see at the bottom the adverse events of special interest, and in particular ILD or pneumonitis, as many of us also call it. And that's seen in roughly around 10% of patients. The majority of these patients has low grade 1 or grade 2 ILD, but it can be significant if not well managed. And unfortunately, in this trial, 3 patients passed away as a result of ILD. If you look at the other side effects associated with trastuzumab deruxtecan, you see this in the upper half of the slide. Again, one of the things clinicians, and actually also all of us had to get our head around this, is these next generation ADCs are essentially like single agent chemotherapy. The side effect profile is not better, but also not worse. Each drug has a very distinctive side effect profile. But when we go back to the second generation ADCs, they were sometimes a little bit more like antibodies. Now these drugs are more like single agent chemotherapy, and that's important when you manage the side effects for patients. It's, for example, nausea, as here highlighted, is higher than with treatment of physician's choice. But that was in the initial trials where we didn't give optimal antiemetic prophylaxis. Now with optimal antiemetic prophylaxis, that is actually very well manageable. And that would always be my message to take away is try an optimized management of side effects, because it will lead to better outcomes of patients when they receive these treatments. Just here a short overview of what we do with ILD. The key thing is to detect it as early as possible. That's why we should review patients frequently, clinically at least every 4 to 6 weeks, with a CT scan probably every 9 to 12 weeks, because if ILD does occur, we want to ideally detect it when it's still grade 1, in other words, asymptomatic. In those patients, we should hold the treatment. We should reduce the dose if it took more than 28 days for the ILD to resolve. We can consider, we usually start patients on steroids, oral steroids right away. But the important thing is, if all of this is well managed, patients with grade 1 ILD can continue therapy, whereas patients with grade 2 or higher ILD cannot continue treatment with trastuzumab deruxtecan, even if they have a fantastic benefit of that therapy. And again, just to highlight this, which I know you're all aware of, but every ADC has its own safety profile. So if you say, for example, here, TDM1 on the left side, TDXD on the right side, so two antibody-drug conjugates, both targeting HER2, both using the same antibody, have substantially different side effect profiles. For example, with peripheral neuropathy on the left with TDM1, on the right, more interstitial lung disease with trastuzumab deruxtecan, and a slightly higher rate of nausea. So we again learning that the determinants of ADC toxicity is to one degree the target, but also the payload, the linker, the biology of the ADC, direct antibody effects, and sometimes patient factors. Now, going back to our patient, she unfortunately developed disease progression after about 15 months, and we had to move on to a different treatment option. Now, going back to the treatment algorithm based on the data I just shared with you, this is what we had prior to the introduction of the ADCs, but we have now learned that ADCs can provide a substantial benefit. You've heard from Dr. Tolaney also about the TROP2 targeting ADCs, similarly providing a benefit in second, third line, fourth line setting in ER-positive patients. And so the new standard way we are treating patients at the moment with metastatic ER-positive breast cancer is after first-line chemotherapy. We would, for patients who are HER2 low, for example, consider trastuzumab deruxtecan, as we did in this patient, and then possibly subsequently to sacituzumab govitecan. And patients who are HER2 zero, never had any signs of HER2, again, sacituzumab govitecan is an excellent second-line option for these patients. Research questions that are still open: how much HER2 is actually needed? And there are interesting data that came out at ASCO around ultra low expression of HER2. We will discuss in a second, but also how we sequence and use these ADCs optimally, and can we possibly move them forward into a first-line setting. Now, this is where we go to our second patient, 62-year-old woman who was diagnosed in 2019, again with locally advanced breast cancer, received neoadjuvant therapy, had adjuvant endocrine therapy, and again had relatively early disease recurrence in liver and bone. Within, if you look at the dates, within just over 2 years after she was started on letrozole. What would you do with such a patient? Would you do a biopsy? Would you do a liquid biopsy? Would you give endocrine therapy, combination endocrine therapy, back to the discussion we had earlier? Would you give capecitabine, or would you give trastuzumab deruxtecan? We know from the primary tumor prior to the start of chemotherapy and after the neoadjuvant chemotherapy was classified as HER2 zero. Now, we performed testing in this patient, did another biopsy, it came back as HER2 zero. We also did a liquid biopsy, and that showed that the patient did not carry an ESR, or the tumor didn't carry an ESR1 mutation and a PIK3CA mutation. So we still decided at that time to give first-line endocrine treatment with fulvestrant and ribociclib. But you can see the activity was unfortunately very low. Disease progression in 4 months, and going back to the discussion we had earlier, you have a first-line endocrine therapy with CDK4/6, progression within 4 months, multiple liver metastases. What would you do? Would you go down and give further endocrine therapy? Or is this one of those patients who we call hormone refractory, even after just one line of treatment, and then consider either chemotherapy or possibly antibody-drug conjugates. Again, we had time to do a repeat biopsy, and there was no targetable mutation from a hormone therapy point of view in ESR1 and PIK3CA. But when we read the histology report carefully, it said HER2 was 0, but actually there was a little bit of staining present, and that's why I've put a plus behind the 0. This is what you sometimes get in your pathology reports. So we had a trial open. The patient was considered on for trastuzumab deruxtecan and had a good treatment benefit. That brings us to this whole discussion around HER2 staining. Now we already spoke about HER2 low, and HER2 low means IHC2 plus not amplified. IHC2 plus means that more than at 10% of cells we have weak to moderate but complete membrane staining. IHC1 plus again means in more than 10% of cells, but it's only faint staining or incomplete membrane staining. But there's a third group where we now have clinical data that's classified as HER2 ultra low. And ultra low means less than 10% of cells show a little bit of HER2 staining, faint, incomplete staining. And they are still classified as IHC 0, but they're IHC 0 with a plus there. And that's important that we discuss that with our pathologist, because there is obviously clearly a difference in the HER2 signal in those patients. Why is this now clinically relevant? It's clinically relevant because of the DESTINY-Breast06 trial data presented at ASCO. DESTINY-Breast06 is a first-line trial in metastatic ER-positive breast cancer with low or ultra-low HER2 expression. Patients were randomized 1-to-1 to either HER2 targeting ADC trastuzumab deruxtecan or to treatment of physician's choice. And there was either capecitabine in 60% of the patients, or paclitaxel or nab-paclitaxel in the remaining 30% of the patients. If we look at the HER2 definitions, we already went through this. HER2 low means IHC1 plus or 2 plus. HER2 ultra low means IHC 0 with membrane staining, patients with chemotherapy naive. And going back to our endocrine treatment discussion earlier, they either had to have had 2 or more lines of endocrine therapy for metastatic disease, or 1 line of endocrine therapy, but progression within 6 months of starting a first-line endocrine therapy. So rapid progressor, like this patients who have hormone refractory disease, or very early disease recurrence within 2 years of starting adjuvant endocrine treatment. A trial at primary endpoint in progression-free survival, secondary endpoints, progression-free survival in HER2 low and ultra low, and overall survival. And you see the testing strategy in the right bottom corner. If you look at the study population, the HER2 ultra low group was about 17% of patients. The remaining patients were HER2 1 plus or 2 plus. About 30% de novo metastatic disease. Most patients visceral disease. Majority of patients had taxanes or anthracyclines, 41, 47%. And primary endocrine resistance were 31% of patients, and 9% of patients progressed within 6 months from starting on a CDK4/6 inhibitor therapy. If you look at the primary endpoint progression-free survival on the left side in HER2 low, you can see a significant, in my opinion, meaningful improvement in progression-free survival, 5 months delta from 8.1 to 30.2 months, hazard ratio 0.62. And on the right side, you see the progression-free survival in the ITT population that includes the patient with ultra-low expression, basically identical results, 13.2 versus 8 months. If you look at overall survival, again, this is an early time point, and the majority of patients, fortunately, haven't had the required event. But you can see hazard ratio shows a clear trend. We see a separation of the curves, but there's also, of course, crossover, and we will need to see whether that impacts long-term survival data. 20% of patients in the treatment of physician's choice received trastuzumab deruxtecan subsequently, and we know it can improve survival in a second-line setting. If you focus on patients with HER2 ultra low, and there was only 152 patients, but you can see very similar characteristics compared to the overall study, both in PFS on the left and overall survival on the right side, with a hazard ratio of 0.78, 0.75, and the medians from 8 to 13 as well. Looking at the progression-free survival overall in subgroups, as you can see, I would call this a very consistent benefit across all subgroups, including the subgroups defined by IHC for HER2, but also by prior CDK4/6 inhibitor therapy, by endocrine resistance, but also by the choice of chemotherapy that was used in the control arm. I always come back to response. And that sounds terribly old-fashioned, but I think response is really important for patients, not just progression-free survival. And it's going back to a point Neil made earlier. Response will lead to a decrease in the tumor burden. And if patients have symptomatic disease, that leads to symptomatic improvement and an improvement in the quality of life. It also allows patients to start their next line of therapy, often with a lower tumor burden, and that can be positive as well. So looking in this first-line study, now the response rate, you can see 56% in the HER2 low group, 61% in the HER2 ultra low group with trastuzumab deruxtecan, compared to 32% and 26% with standard chemotherapy. So more than doubling, or roughly doubling of the response, which is a trend we see with all ADCs. We saw this in later lines. We see this with TROP2 targeted ADCs as well. And it's one of the key benefits for me for those ADCs that they drive a very high response rate. Looking at the safety profile, it looks very, very similar to what we know, what we've seen in DESTINY-Breast04. So I wouldn't say there were any new safety signals. It is the known profile of trastuzumab deruxtecan, also with the known distinct side effects of interstitial lung disease, ILD, or cardiac effects in a small percentage of patients. Now, one of the questions that remains is, what is the best sequence for HER2 targeting ADCs at the moment? And I've done something here which one obviously isn't allowed to do. So please take this slide with a pinch of salt. But I thought it would be helpful just to put the first-line data and the second-line data in an artificial sequence. And we see in first-line setting, we have 13 months TDXD progression-free survival compared to 8 months with treatment of physician's choice. But then in the second-line setting, we also saw patients who have TDXD in DESTINY-Breast04 had 10 months PFS compared to 5.4 months with treatment of physician's choice. And if it was possible to put both lines behind each other, and obviously this is not a trial that took place, they're looking at those sequences, it looks like a relatively similar combined progression-free survival of the first 2 lines of therapy. What is remarkably different is the response rate between the 2 strategies. And so it's probably not a situation where one treatment and one strategy fits all patients. I think in patients with less aggressive disease, it remains an excellent option to give standard chemotherapy and then have ADCs such as TDXD in the second-line option. But for example, in patients with very active disease where you need an urgent response, you may want to benefit from the higher response rate and therefore give an ADC, therefore give TDXD at an earlier stage. The impact on quality of life is obviously something we will have to see of those strategies. But again, the impact of quality of life is also dependent on how well we as teams manage those side effects. And it gets back to optimal antiemetic therapy and all the other things we have learned over years. And I would clearly say that the tolerability of ADCs these days is substantially better than it was 4 or 5 years ago.
I really love this idea that you put together, this graphic, but just kind of curious, if you did that instead of putting TPC and put sacituzumab.
Yeah, it's a difficult question. So we obviously haven't got sacituzumab govitecan data in the first-line setting at the moment, and what we don't know is how good the activity of a topo-1 payload ADC after prior topo-1 payload ADC. Now we have some anecdotal data that there is activity, and we know that some of the resistance is down to payload, some of the resistance down to the target. But ultimately, what those ADCs all use is a very similar chemotherapy, and so I think SG would probably be relatively similar to treatment of physician's choice, but we do not know whether the second-line ADC after first-line ADC provides the same benefit as we see, because I think there's some cross-resistance in terms of payload.
I understand. Please continue.
So we go back to our patient who received now trastuzumab deruxtecan for HER2, actually ultra-low disease, as a first-line therapy. She had a good partial response, but then unfortunately, 7 months after she started the therapy, most of the scan was still looking great. She still had a good partial response, but one of the liver mets started growing. Now that is formally progressive disease, but you could also say it's oligoprogressive disease because it's just one of those lesions. So what would you do? Would you just continue because the majority of the disease is well controlled? Would you give local therapy, stereotactic radiosurgery or radiofrequency ablation, and continue with trastuzumab deruxtecan, switch to chemotherapy, or switch, as we just discussed, to sacituzumab govitecan? And in this context, it's interesting to look at what we know about ADCs and resistance to this. And these are data, well, actually this time with JOP2 targeted ADCs, but I think the principle can be extrapolated to all ADCs. And what the group from Dana-Farber did was looking at the different metastatic lesions. In this patient, biopsies were taken 2 from above the diaphragm, 2 from below the diaphragm, liver, and periaortic lymph nodes, and then checked for JOP2 binding site, but also for the topoisomerase binding site. And what they could see is that in the very same patient, in 2 of the metastatic lesions, JOP2 binding was altered. So there was resistance to the actual target of the ADC. In other 2 lesions, there was resistance to the payload, to the chemotherapy drug. And that teaches us a lot about resistance to ADCs. It can often be subclonal. And that's why we will see, and we're already seeing more often what we call oligoprogression. If you have 10 sites of metastatic disease, 9 are responding, 1 is growing, that's oligoprogression. And in those situations, it may make sense to give local therapy for that one resistant clone if the other clones are still benefiting from the therapy. We will need to work on rational sequences. There will be new combinations required in terms of payloads, but also I'm personally quite biased, obviously, but quite excited about the combination with immune therapy. So going back to our patient, we gave cyberknife therapy to the liver metastasis, obviously with a good effect, continued with trastuzumab deruxtecan, and she could stay on the very same treatment for another 6 months. Eventually, unfortunately, she had further disease progression, this time in multiple sites, and she was rebiopsied. She was still HER2 ultra low, but clearly they had resistance had kicked in, which we assumed was resistant to the payload. So again, the question, what would you do? Would you continue without a change? Our feeling was that's not the right thing to do because of progression in multiple sites. Would you switch to sacituzumab govitecan, another ADC, but using a similar payload? Would you switch to chemotherapy or possibly consider a different ADC in a trial, and there in particular an ADC with a different payload? And this is an incomplete list of the targets for ADCs we are currently exploring. Now, it goes from Nectin-4 to B7H4, TROP2. You obviously heard a lot about LIV-1, HER2, HER3, just to mention a few of those. Now, one really interesting point, in my opinion, important point to make. In the past, we were always targeting what I would describe as the oncogenic driver, what was driving the biology of the cancer. With the novel generation of ADCs, with the bystander effect, we do no longer have to target the oncogenic driver. We can target any antigen as long as it is expressed on the cancer cell or even on the tumor stroma. And that's why we have this plethora of new targets coming through that are biologically not necessarily relevant, but are fantastic anchors for our targeted therapy. Now, the drugs that are through phase 3 trials with positive data, you've heard a lot today already with TROP2 target ADCs and with trastuzumab deruxtecan as a HER2 target ADCs. But there are also other ADCs coming through. For example, HER3 target ADC patritumab uses, again, deruxtecan as a platform. We've seen an interesting response rate of around 22%. And then SGN LIV-1A, with a response of 28%. These all share good responses in a number of patients. We also just had at ASCO the first data with what I would call EV on enfortumab vedotin, and that's an interesting drug. It targets Nectin-4, which is probably not the most highly expressed target in breast cancer, but it uses a different payload class. This time it's an anti-microtubule agent compared to all the top, I summarized one inhibitors we used with the TROP2 ADC so far, or with the HER2 ADC so far. And I think that offers a good benefit possibly for patients, especially if they may have developed the resistance to the payload. Now, the data you saw at ASCO were data from a larger trial, but the ER positive and triple negative cohorts were separately read out. 20 patients in interim analysis, 4 patients with response, or 3 patients with response in TNBC, and then the cohorts were supposed to be expanded. And what you can see here is the objective response rates. On the left side in ER positive disease with about 15%, on the right side in triple negative disease with around 19%. And it's probably a little bit too small to see on the slide, but the little number on the vertical plots gives you an indication of the Nectin-4 expression. And the conclusion of the authors was that actually the response was seen relatively regardless of Nectin expression, even in some of the lower expressing patients. PFS 3.5 months, duration of response 4 months in TNBC, 7 months in ER positive disease, overall survival 12 months and 19 months respectively. Now it's a little bit difficult to know what to make of those data. What I saw in Erica Hamilton's presentation at ASCO as well from the same trial, it wasn't the main presentation, was data on progression-free survival, but with or without prior use of sacituzumab. And actually a progression-free survival of about 3.5 months after sacituzumab govitecan is pretty impressive. If you look back at the phase 3 study in triple-negative breast cancer, sacituzumab govitecan versus treatment of physician's choice, the median PFS in the control arm, and that was in that line, was 1.7 months. So this is clearly better. It's not as good as one would hope, but it clearly shows that a second ADC after the first ADC may be beneficial. And that's a strategy we chose in this patient with a short-term benefit, but just to highlight the example that we can use ADCs, ideally, not just with different targets, but also with different payloads. So my summary for non-TROP2 targeted ADCs today and tomorrow, it's essentially a targeted delivery tool for a chemotherapy into cancer cells. But as I highlight, the target does no longer need to be an oncogenic driver. There's still some off-target toxicity, so it's not a perfect strategy yet. But what's really exciting is those new ADCs are highly effective, even with very low or ultra low or almost undetectable target. And we have approved agents have now a membrane permeable payload, which is obviously leading to this bystander effect that drives this increased activity. We have had a remarkable success over the last 2 or 3 years. You have seen and you are aware that ADCs are now part of guidelines for all metastatic breast cancer subtypes, from ER positive to HER2 positive to triple negative. It even resulted in the definition of a new subgroup, HER2 low. But we are also, of course, exploring now those ADCs in earlier disease setting. I shared with you the first-line data, which is not yet licensed, but we also see data in the neoadjuvant and adjuvant setting. For future development, what is important, in my opinion, is we need to learn a little bit more about the intensity, the distribution, but also the dynamics over time of the target expression. There's an urgent need for different payloads, and the relevance for sequential strategies is clear because we need non-topo-1 payloads, ADCs, urgently in clinical settings. And it will be interesting to see more about combinations in TNBC, and I haven't spoken about that today, but very happy to discuss it as well. Our experience with IO combinations is very encouraging, and I look forward to seeing more in larger trials.